ಸರ್ ಬಂದಿಲ್ಲ.
ಇಲ್ಲ, not received.
No?
Yeah.
ನಮಸ್ಕಾರ ಸುನೈನಾ.
ನಮಸ್ತೆ ಮ್ಯಾಮ್. ಹೌ ಆರ್ ಯು?
ಫೈನ್, ಥ್ಯಾಂಕ್ ಯು. ಆ ಜನನಿ ಈಗ ನೀವು ಎಷ್ಟು ಹೆಲ್ಪ್ ಮಾಡಿ ತುಂಬಾ ನೆನ್ಸ್ಕೊತಾ ಇರ್ತೀವಿ ನಿಮ್ಮನ್ನ.
ಈಗ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಮ್ಯಾಮ್.
ಈಗ ನಮ್ಮ ಆರೋಗ್ಯ ಕೇಂದ್ರ 2 ಸೆಂಟರ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ನಾವೇ ಈಗ ಸದ್ಯಕ್ಕೆ ಕಾಲ್ ತಗೋತಾ ಇದ್ವಿ. ಐ ವಾಂಟ್ ಟು ಸ್ಟಡಿ ದ ಮಾಡೆಲ್ ಅಂಡ್
ಓಕೆ ಓಕೆ ಮ್ಯಾಮ್.
Ma'am, with the permission,
Anybody else has?
do we start? We are waiting for our president, sir,
Okay, okay. Just
Dr. Kasturi. I'll
I
just
will
call
ask
her.
Arun to give a call. Okay?
Yes, sir.
Yes, sir. Arun, give a call to Kasturi. Yes, sir.
ಸುಮಾ ಎಲ್ಲಿ ಬಂದ್ರ?
ಸುಮಾ ಕಾಣ್ತಾ ಇಲ್ಲ, ವಿಡಿಯೋ ಕಾಣ್ತಾ ಇಲ್ಲ ಸುಮಾ. ಒಂದೇ ನೇಮ್ ಇಸ್ ಸೀನ್. ಸುಮಾ ಎಲ್ಲಿದ್ದೀರಾ?
ಅದು ಲ್ಯಾಪ್ಟಾಪ್ ಸ್ವಲ್ಪ ಪ್ರಾಬ್ಲಮ್ ಆಗಿದೆ ಸರ್, ಅದನ್ನ ಅಡ್ಜಸ್ಟ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಗುಡ್ ಈವ್ನಿಂಗ್ ಹೇಮಾ ಮೇಡಮ್, ಆಗ್ಲೇ ವಿಶ್ ಮಾಡಿದೆ, ನೀವು ಗಮನಿಸ್ಲಿಲ್ಲ ಅನ್ಸುತ್ತೆ.
ಹೌದೇನು? ಅದಕ್ಕೆ ನಾನು ಹುಡ್ಕಾಡ್ತಾ ಇದ್ದೆ. ನಾಗರಾಜ್ ಸರ್, ಭಾರತಿ, ಹೈ.
You can see it at this one, PPT.
No.
What I've shared.
ತುಂಬಾ ಶೇರ್ ಮಾಡಕ್ ಟ್ರೈ ಮಾಡ್ತಾ ಇದ್ಯಾ?
ಆಯ್ತು. 1 second. Yeah.
Yes.
I think now it's. Oh,
Yes.
Yeah. Yes.
Perfect.
Okay.
Nice.
Okay, I'm not reaching out to our president actually.
Madam, in 2 minutes, madam will be joining.
Okay.
Hey ma'am, good evening. I called you avagle.
Good evening. I know everybody is biting their nails for the voting ಅಲ್ಲ. ನಾಳೆ vote ಮಾಡಿ. ನಾವೆಲ್ಲ ಫಸ್ಟ್ ಟಕ್ಕಂತ ಬಟನ್.
Hello.
MG ಸರ್ ಹಾಕಿದ್ರಿ ಅಲ್ವಾ?
100% voting everybody has done.
Oh, super.
Yes.
ಹೇಮಾ ಮ್ಯಾಮ್ ಯಾವಾಗ ಬಂದ್ರಿ ವಾಪಸ್ಸು ಈಜಿಪ್ಟ್ ಇಂದ?
ನಾನು ಈಜಿಪ್ಟ್ ಇಂದ ಲಾಸ್ಟ್ ಫ್ರೈಡೆ ಬಂದು ಸ್ಯಾಟರ್ಡೆ ಅಹಮದಾಬಾದ್ ಹೋಗಿ ತಿರುಗು ಟ್ಯೂಸ್ಡೇ ಡೆಲ್ಲಿಗೆ ಹೋಗಿ ಇವತ್ತು ತಿರುಗು ವಾಪಸ್ ಬಂದಿದ್ದು. ಅಷ್ಟೇ.
ನೈಸ್. ಗುಡ್.
ತಿರುಗು ಟ್ಯೂಸ್ಡೇ ಕೋಲಾರ್ ಟಾಟಾಸ್ ಒಂದು ದೊಡ್ಡ ಇದು ಪ್ರಾಜೆಕ್ಟ್ ಇದೆ, ನೋಡ್ಕೊಂಡು ಬಂದು ಇಲ್ಲಿ ನಿಮ್ಗೆಲ್ಲ ಶೇರ್ ಮಾಡ್ತೀನಿ ಆಮೇಲೆ.
ನೈಸ್. ಗುಡ್.
Hi Manjula.
ಮ್ಯಾಮ್ ಹಲೋ. ಆವಾಗ್ಲೇ ಆಕ್ಚುಲಿ ನಾನ್ ಹೇಳ್ದೆ ಮೋಸ್ಟ್ಲಿ ನೀವು ನಿಮ್ದೇನೋ ಲ್ಯಾಪ್ಟಾಪ್ ಏನೋ ಪ್ರಾಬ್ಲಮ್ ಆಗಿತ್ತು.
ಆಡಿಯೋ ಪ್ರಾಬ್ಲಮ್ ಆಗಿತ್ತು, ಈಗ ಸ್ವಲ್ಪ ಸೆಟ್ ಮಾಡಿದೆ.
Now Suma is visible.
Yes.
So we are waiting for Dr. Kasturi and Dr. Vidya Thobi.
Yeah, I've joined you.
ವಿದ್ಯಾತೃಪ್ತಿ ಮೇಡಮ್ ಮಾತಾಡಿದ್ರಲ್ವಾ ಈಗ?
Yes. Okay.
Sonia, I've joined.
Yes,
Kastur
madam.
is
Thank
joined,
you
yeah.
so much. Then we'll get started, madam.
Okay.
You're on time.
Yeah.
ಹಲೋ ಕಸ್ತೂರಿ ಮ್ಯಾಮ್, ಗುಡ್ ಈವ್ನಿಂಗ್.
Hello. Good evening, Manjula. In one day,
Ma'am, I need all your wishes.
we wish you all the best. Wish you all the best.
Thank you.
One more day.
Yes,
Yes,
one day
yes, yes.
today ಎಲ್ಲರೂ ಇದು ಮಾಡಬೇಕು.
Ma'am,
I think we would get started.
Yeah.
Namaste. Good evening, everyone. Ellargu Shubha Sanje. I bring greetings from Safe Motherhood Committee, Kasoga. We are very happy to conduct a webinar in association with KSC ACOI, that is Association of
ACOI.
Gynecologic Oncologists of India, which is supported by Motherhood Hospital, Mysuru. Month of February, we all are aware it is National Cancer Prevention Month. So we chose the topic malignancy in pregnancy for today's discussion. We all know pregnancy itself do not constitute a predisposing factor for malignancy, but management and treatment is a challenge in everyday clinical practice. Malignant disease complicates up to 1 per 1,000 to 2,000 pregnancies. So it's a challenge to the obstetricians who need to confront ethical, emotional, and treatment modalities. To start today's program, I seek blessings of the Almighty, our gurus, professors, by continuing with virtual lamp lighting. Now I request Mr. Arun to do the needful.
Hello.
Arun, start ಮಾಡಿ.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा.
Thank you. Lighting the lamp signifies spread of knowledge, that is light of knowledge today. With this note, today we have here on a virtual platform to enrich our knowledge about PAC, that is PAC, that is pregnancy associated cancer, which is defined as cancer that is detected during pregnancy and up to 1 year postpartum. So an update of the imaging triage, that is safety considerations, cancer specific imagings, and treatment options of PAC will be discussed this evening. For which I now request Dr. Bharti Rajshekar, a dynamic secretary of Kasoga, Malenadina Kanye, Malenadina Sundari. Her name says it all. It starts with B, brave and beautiful, and ends with I, an important personality who will flag off this Kasoga webinar now. So, Madam, on behalf of Team Safe Motherhood Committee, we welcome you and also request you to flag off this webinar.
Thank you, Dr. Sonia. Beauty is always in the eye of the beholder, where each one has our own importance.
ವಾವ್ ಎರಡು ಕಡೆಯಿಂದ ಚೆನ್ನಾಗಿ ಹರಿದು ಬರ್ತಾ ಇದೆ.
Well, as Sonia has already elaborated, pregnancy and cancer are very sad situation, a very tricky situation, and it often leaves us in a dilemma as what to do next. How do we save the pregnancy or how do we save the mother? And to speak about this very important topic under the aegis of the Safe Motherhood Committee of Kasoga, organized by Dr. Sonia Mandappa from Mysore, we have Dr. Shobha, who is another beauty, and she happens to come from my own family. She is my niece by marriage to my husband's sister. Okay, so Shobha from Kidwai Institute of Oncology will be speaking on this very important topic, which keeps many of us in a very tricky situation and a very desperate situation when we come across such women. So I thank Dr. Sonia for organizing this excellent webinar with this nice topic. And of course, she has chosen a very good speaker from the president of the Karnataka state of Agoy. And we have the doyens, Dr. M.G. Hiremat, Dr. Hema Divakar, Dr. Kasturi Donimat, Dr. Nagaraj, Dr. Vidya Tobi, and all my friends of Kasoga and participants from MOGS and all over Karnataka. So over to you, Dr. Sonia, to continue with the session. Thank you for giving me this honor.
Thank you so much, ma'am. I'm profoundly delighted to take this opportunity to invite our chief guest, patron of Kasoga, Dr. Hiremat, for which I call upon Dr. Manjula Patil, my own friend, Mrs. Smile of Kasoga, to welcome and introduce Dr. Hiremat.
Thank you, Sonia. It's always a pleasure to introduce MG sir, and actually who does not require any introduction at all, since he's been the pillar of Kasoga since its starting with the Kasoga conferences. So he's been the pillar of Kasoga as well as KCOG, which he introduced 2 years back, and which is doing wonderful. And because of that, the Kasoga platform has got more value and people are coming forward to serve Kasoga to the great extent. Now, he's the current principal of KAHR's JGMM Medical College, Hubballi, and is an academic council member of the same university. And he's a chief patron and founder secretary of KSOGA. And he was former director of Karnataka Institute of Medical Sciences, director of Health IVF Center, and he was the past vice president of FOXI, ex-chairman of Best Committee, FOXI, and he's been the pillar of so many youngsters in Kasoga. I welcome you, sir, and for your valuable words for the audience.
Yeah. Thank you, Manjula, for your nice words. Actually, there is
you,
no
sir.
need to introduce at all. First of all, good evening to everybody. What a nice program today, because in this February, we are all celebrating the programs of academics on the cancer. Sonia, ever beautiful and dynamic person, has chosen always the nice topics. Today also, she has chosen a very wonderful topic with a very nice speaker who is day in and day out is involved in cancer surgeries. But as far as our experience with the cancer in pregnancy, what I have observed is we are very lucky that Almighty has not given much incidence and prevalence of this disease. If you look at number of pregnancies, number of delivery, hardly we see cancers in pregnancy. I think that is the boon for the woman. But however, there are some incidences where the cancers do occur in pregnancy, and it is a very, very complicated. As you know that pregnancy itself is a risk, and over that, and another risk is added. I think that is the most difficult situation to diagnose and to manage and even to investigate with various modalities when the fetus is in utero. I think this is the most complex problem I can say in pregnancy. I think the right persons today, because we have evolved into so many super specialty, gynec oncology is a very big super specialty, and definitely our gynae oncologists have doing a wonderful job. and today's webinar should give a more highlight on this subject. Thank you, Sonia, for pressurizing me to be today at any cost. I have winded up all my programs in the evening, 4 o'clock, and came here at 6 o'clock only with my searching for laptop, everything. And I'm very thankful. I'm very much thankful to you for making me to join. And
Thank you, sir.
and more, Sonia personally is a very good friend of mine for more than 25 years. And when she took this job of a chairperson, I can tell you she is the number one who has taken it so serious and has done to the best of her ability. And she has actually upgraded the Safe Motherhood Committee in Kasoga. I think this is what we thought 2 years back when we made the chairperson. We thought, let us give it to youngsters because they have got so much energy and so much zeal to do. I think she is an example for that. With these few words, Sonia, thank you very much for giving me this opportunity again.
Thanks for gracing the occasion, sir. Thank you so much. We team Safe Motherhood Committee would like to extend a special welcome to our guest of honor, Dean KCOG, Advisor of Safe Motherhood Committee, Dr. Hema Divakar. I now request and I call upon Dr. Rekha, who's Safe Motherhood Committee representative of Shivamogga, to introduce a lady with distinct vision, passion, and an inspiring personality to this audience. Dr. Rekha, over to you.
Good evening, respected seniors and friends. It's my proud privilege to introduce Dr. Hema Divakar, madam. She is well known to all of us by her immense work and doesn't need any introduction, but yet I shall do the formality. Dr. Hema Divakar, madam, is the medical director of Divakar's Specialty Hospital. She's a senior consultant OBGYN. She is CEO and chairman of Asian Research and Training Institute for Skill Transfer. She is the dean of Karnataka College of Obs and Gynae. She is the vice president of Karnataka Association of Healthcare Providers India. She is the chair of Well Women Healthcare at FIGO. She is the president of DIPSI, Diabetes and Pregnancy Study Group of India. She is the ex-vice chair for FIGO PNCD Committee. She is the past president of FOXI 2013. She is an advocate for delivering quality healthcare, convener, Manyata. She is an opinion leader and an influencer for social and legal issues relating to women's health. Coming to her awards and recognitions, Madam is FIGO Women Achieve. She has received FIGO Women Achievers Award in 2015. She has received Global Asian of the Year 2018, CME Excellence Award for Artist, Next Brands Award for Artist for her. She has also received CSR Times Award, that is CSR Impact Award for Divakar's Service Trust. I welcome you, madam.
Thank you. Ellarigu namaskara. Thank you, Rekha, for those kind words. And today's very special topic, as Hirimat said, pregnancy and cancer. Cancer invades. And so does Sonia, because her energy and enthusiasm has all pervaded the members of the Safe Motherhood Committee, and beyond that, having won accolades for her work, and of course, our immense appreciation, because we need the action-packed doers, and here is one for you, Sonia. Congratulations for a job very well done. Same breath, I cannot resist acknowledging that Hirimat is the one who has kept us all together for decades, and somehow he hit upon the idea of KCOG and made me the dean, so that we are somehow engaged in the Kasoga activities one way or the other. That is a very special, knack he has to make us feel important and also make us feel very responsible for doing more to our own organization, and I really appreciate that. And the present office bearers who are at the brink of the transition of handing over, congratulations, Kasturi and team, for a brilliant performance during your tenure of presidency. Now coming to the topic of pregnancy and cancer. See, so much we are talking about high-risk pregnancies. Seldom we talk about pregnancy and cancer. And it's like a nightmare. It is striking my memory very, very strong, Shobha, where 3 years ago, one of my own relative who was pregnant for the second time, and incidentally, at 28 weeks of pregnancy, there's a very cursory breast examination by my assistant doctor. See, over the period of time, somehow the routine breast examination during pregnancy, it's not like a very standardized norm. Means we do it sometimes, so it's feeling like a little hard. So then I said, okay, I didn't want to be indifferent to her findings. So I went and then saw that, and it was really a hard mass in the breast. And then the heart missed a beat, and I said, oh God, this doesn't look like, anything normal. And then we called for the specialist oncologist, and then there was such a huge dilemma because pregnancy, 28 weeks, we know we can send her to a tertiary center to pull out this baby. It may do well in the intensive care, but we don't know how urgent it is. But peculiarly, the patient was very calm, as if she had not understood the situation. That frightened me even more because she's absolutely, she's very cool. She said she was very clear about the fact that she wants to carry to term and then, deliver this baby. And we had absolutely no say in that. And after that, we thought that, her husband was in the US, by the way. By the time we took his sanctions, he was very frightened. He said, you save my wife and you forget the baby. So much. That means the one pregnancy and one cancer, the combination is deadly dilemmas for our minds. That is for sure. And also for the family. And then we thought that, as how she delivers, and then after she's taking the treatment, and how long will she survive? But she survived for 3 years, and it was just about 12 days back that we lost her. But again, I saw like a flash pregnancy and cancer. The flyer from Sonia said, oh God, this is still, continuing to haunt me in my very strong memories. As Sirimat said, very, very rare to see. But once we see them, seriously, we are, in a blind alley. We don't know actually what is the right way forward, even with a multi-stakeholder specialist consultant, because there is so much more to it than individual and cancer and pregnancy and cancer. So it was just building over the complexity of layers. So I really, really appreciate that an expert has been sourced today to throw more light on this very important issue. Even if you encounter it once in a while, you would always wish you knew a little more about it. You can portray your confidence to the patient, but it's really it doesn't happen with the very meager knowledge that we have. So I once again congratulate the entire team for putting us together on this fine evening to discuss and understand more about pregnancy and cancer issue. The knowledge and wisdom, intelligence and intuition to translate into best of the best. Namaste, and thank you for having me here. Sonia, unmute. Sonia, unmute.
Thank you so much, madam. Thanks for your lovely words. I recognize the presence of Dr. Vidya Thobi. Welcome you, ma'am. On this note, we continue our program. For now, I call upon a representative of Safe Motherhood Committee who represents the Hubli Society. Dr. Rashmi, are you there?
She's there.
Yeah, she's
Rashmi is there.
Rashmi, I would want you to introduce our chairpersons of today's program, Dr. Kasturi Donimat and Dr. Suma KB, the humble teachers who's now positioned as professors. And please, I actually had requested Dr. Rashmi, another Rashmi who is representing our Safe Motherhood Committee due to our emergency case. I think she's substituted for another Rashmi too. But then thanks so much, Rashmi. Over to you.
Yes, ma'am. Good evening, ma'am. Yeah, I am Dr. Rashmi Desai, ma'am, present Secretary HDOGS. I am very proud and happy to introduce my teacher of teachers, Dr. Kasturi Donimat, madam.
Please unmute Dr. Rashmi Desai.
Dr.
Rashmi, ಕೇಳಿಸ್ತಾ ಇಲ್ಲ.
She has muted her.
Yes.
Maybe some network problem. I think no need of introduction.
No, madam.
You can carry on.
She's now unmuted. Continue, Rashmi.
She is presently the president of Kasoga. She is professor and head of the department in OBG at KIMS Hubli. She is ex-president HDOGS, ex-secretary general of HDOGS. She is principal investigator for international research projects. She has been MCI inspector to colleges all over India. She is UG and PG examiner in many universities. She is chairman of
It's okay. No. Let us not waste time.
We have seen Madam working, and I would like to compare her with a lake with a great depth who stays calm on the top, but she has great depth of knowledge and enthusiasm and the spirit to work and the passion to work. And we derive great inspiration from her, ma'am. I'm very, very happy to introduce her. And our second guest of honor is Dr. Suma KB, madam, who is professor and unit chief, Department of OBG, JSS Medical College, Mysore. She is undergraduate and postgraduate from JSS Medical College. She holds a PG diploma in medico-legal systems from Symbiosis University, Pune. She is a member of governing body and college council of JSS Medical College. She is a member academic council JSS Ahed. She is an active member of Mysore OBG Society, and her area of interest is high-risk obstetrics. Madam, I thank you for giving me the opportunity to introduce
Dr.
two eminent personalities today.
Thank you, Dr. Rashmi. You took up in such a short notice the task of introducing our professors. And now I think the platform, without wasting much time, will be handed over to the chairpersons. Please carry on the scientific deliberations. Thank you, ma'am.
Thank you, Dr. Sonia. And thank you, Rashmi, for such a beautiful introduction, such beautiful words. You made my day. And first of all, hearty congratulations to Sonia for taking up this such very important topic, very rare, very less discussed topic. You know, we discuss so many malignancy, everything, but in pregnancy is less talked of, less discussed of. So thank you for bringing up this topic, and thank you for pitching in such a eminent faculty, Dr. Shobha from Agoy, who would be better than Dr. Shobha to enlighten everybody, all the Kasogians, on this topic. So it's a very important topic, malignancy in pregnancy, that is, as everybody has told, very rarely encountered, very rarely discussed, very less any evidences, because very few cases we cannot have any RCTs or anything evidence-based. So it's more of experience-based doctor. So even as MD Ramat sir or chief patron was telling, we hardly encounter. Mainly in the past, we are encountering pregnancy with CA cervix, some of them. We have seen some cases pregnancy with CA cervix, and it is a balance we have to do, like whether to deliver, whether we have to give importance to the pregnancy or we have to give importance to the malignancy. So that all depends on what gestational age we have diagnosed, everything. So we have here Dr. Shobha to talk on that. I'll not take much time. So we request Dr. Shobha to carry on. Doctor, any comments from other chairperson, Dr.
Respected teachers and my dear friends, good evening to everybody. At the outset, I would like to thank Kasoga and also the Safe Motherhood Committee Chairman, Dr. Sonia, for giving me this opportunity to chair the session, that too along with our dynamic leader, Dr. Kasturi Donimal. So actually, Dr. Shobha, as I'm seeing now since half an hour, she doesn't require any introduction. So as a formal procedure, I would like to introduce Dr. Shobha to this August gathering. She is actually, I feel very proud to say that she did her post-graduation from JSS Medical College. So three of us are here, JSS, Dr. Sonia, myself, and Dr. Shobha. Sure. And she has done MCH in surgical oncology, and she is... Oh, sorry.
Manjula. Manjula, yes.
Shobha has done NCH in surgical oncology, and she is a specialist in breast and gynecological oncology. At present, she is working as associate professor in the Department of Obstetrics and Department of Gynecological Oncology in Kidwai Memorial Institute with the experience of 15 years. And she is also heading the secretary of the Karnataka Association of Karnataka chapter of Association of Gyne-Oncologists of India. And she is the president-elect, and she will be holding the chair of the president next year. And she is a reviewer in national and international journals related to gyne-oncology, and also she is a speaker in various national and international forums. And she has published articles in national and international journals and credited with several presentations. So she has got most of the, among all the things, she has got a special interest in preventive oncology, mainly related to breast and cervical cancers. So I welcome Dr. Shobha. So over to you, Shobha, to enlighten us about malignancies in relation to pregnancy.
Thank you, madam. Thank you so much for the kind introduction. Respected chairpersons, seniors, respected seniors, and dear friends. At the outset, I thank Dr. Sonia for inviting me for this platform. I think which is very important that all of us who are practicing obs, gynae, and gynec-oncology, it's very important to know at least what, when we come across cancer during pregnancy, what we can do from our side. We shouldn't miss anything. So what is the least we can do? So it's actually, though, as Sir said, it's a rare thing what we encounter in pregnancy, but still we should know the basic evaluation and workup of any malignancy, which is common in pregnancy. So today, mainly I'll be focusing on gynec malignancy and breast malignancy due to lack of time. Very small things are there which we have to highlight. So I think in this short duration, we can cover that, which we come across quite frequently. Can I share the...
Yeah, you can share your slides.
Yeah. Is it seen?
Yes.
It's coming.
I can't see. Okay.
We can see, sir.
Yeah, this is the one? Okay.
Yeah, you can make it full screen.
Yeah.
Yes,
We can see now.
So the outline of my talk will be introduction and how do we diagnose cancer during pregnancy, what is the prognosis of these cancers, and then general considerations, what we have to do when we have to think about managing these, and then diagnostic criteria, whether it differs from the usual criteria of malignancy, and how safe is the management, the surgical management done in cancer with pregnancy, or how safe is the chemotherapy administration and radiation, and what are the fetal obstetrical outcome, care we have to give and outcome. So, sorry. Cancer associated with pregnancy are quite rare. So it is 1 in 1,000 to 2,000 pregnancies. But prevalence is rising now, I think maybe due to the increasing maternal age. So which we are seeing above 30 years, we are seeing a lot of people who are conceiving for the first time, especially working career-oriented ladies. We have between 35 to 40 years also who are conceiving. So that increasing maternal age and non-invasive prenatal test, what is being done, that also is coincidentally detecting some chromosomal aberration in them. So prevalence is slightly raising. So, but most common cancers in pregnancy, what we come across is the breast cancer, followed by cervical cancer. Then we have lymphomas, ovarian cancer, leukemia, malignant melanoma, and colorectal cancers. So this is the incidence. So breast cancer is the most common, 10 to 30 per 1 lakh, followed by lymphoma also is quite common, and then followed by cervical and leukemias. So coming to diagnosis. So often the diagnosis is delayed in pregnancy. Why? Because the symptoms, signs and symptoms during pregnancy mimic, the cancer symptoms and pregnancy symptoms mimic each other. So that's why there is a delay in the diagnosis. So symptoms like fatigue, breast changes, anemia, nausea, indigestion, vaginal discharge, rectal bleeding. So these could be common symptoms associated with pregnancy changes, pregnancy induced. So we might take it a little lightly. Then maybe after a couple of days or months, then maybe we might get into the seriousness of the symptoms. So hence, usually it is often delayed. But most cancers, that is 64% of them associated with pregnancy, are diagnosed after delivery, that is postpartum, during the first year of postpartum or during lactational period. So pregnancy itself does not appear to worsen the prognosis when it is diagnosed in pregnant women. But pregnancy-associated breast cancer, which occur most commonly in young group, may have some kind of high-grade tumors, or they can have estrogen-negative tumors. Hence, the prognosis can be poor. But as such, be it cervical cancer or ovarian cancer, it does not show to reduce the survival when it is diagnosed in pregnancy. So how do we manage cancers in pregnancy? So we should follow guidelines and recommendations of those what we follow in non-pregnant female. So oncological principles should be maintained. So, and also we have to keep in mind the gestational age, the expected prognosis of the mother depending on the stage, and of course wishes and concerns of the parents. As madam told that time, her relative, so she wanted to continue her pregnancy. So some people are insistent, even though we say it might be little locally advanced or advanced, they might have the desire to continue the pregnancy. So we have to carefully weigh the risks and benefits of both to the mother and the baby, and then take a decision. And then of course, ethical issues we should never forget. So, sorry. So what about radiation during pregnancy? So whenever there is high dose of, she is exposed to high dose of radiation, definitely medical termination should be considered. So when, especially the high threshold level is between more than 150 milligrays. So gross congenital malformations are seen at 200 milligrays itself. So lifetime cancer risk development when they're exposed in utero is 3%. Hence, we have to avoid unnecessary procedure and balance the maternal and fetal benefits and risk. What about surgery during pregnancy? Surgery during pregnancy is considered quite safe in all, in second trimester. So with special precautions. So we can do all abdominal or non-abdominal or non-genital organs safely. We can do surgery, but not during the first trimester, but in the second trimester. So coming as such to the breast cancer now in pregnancy, which is the most common cancer. So it occurs in about 1 in 1,000 to 2,000 pregnant women, and average age of occurrence is between 32 years and 38 years. So definition is gestational breast cancer whenever it is diagnosed during pregnancy or in the first year of the postpartum or during lactational period, then we define as gestational breast cancer. And it is a challenging thing to manage because here breast conservation surgery always requires adjuvant radiation, which we cannot give during pregnancy. So definitely we'll have to modify our management. And so neoadjuvant chemotherapy is an option here to delay surgery until delivery. So how do we manage breast cancer in pregnancy? Yeah, so workup, we have to work up according to the guidelines. So we have to involve a multidisciplinary team, and see whenever we examine the breast, maybe detected by the patient itself or by routine obstetrics examination, you might detect some breast lump. So if it is suspicious lumps, if there are pregnancy-induced changes in the breast as such, but a malignant breast lump definitely feels a well-defined non-tender mass lump. So if it is suspicious, we'll have to, first thing what we have to do is a breast ultrasound. So MRI is not needed routinely, but if at all, if ultrasound is not conclusive, then an option of MRI can be kept. Okay, but breast ultrasound is the first option. So then followed by that is the ultrasound guided. So if it is suspicious, then we'll have to do ultrasound guided TrueCut biopsy. So here cytology is not so conclusive. So better to avoid cytology. FNSC is not advisable as a first step of approach. So TrueCut biopsy, which is ultrasound guided. Then mammogram should be done once the cancer is confirmed, because we have to see whether it is a multicentric disease or whether the contralateral breast also involved or not. So mammogram with proper fetal shielding should be done. Then chest X-ray, yes, of course, to know the minimum basic metastatic workup, chest X-ray, is it safe enough? Yes, with a good shield, abdominal shielding. One chest X-ray do not cause so much of radiation to the fetus. So less than 0.01 is the radiation emitted through the chest X-ray, which is quite safe. So liver ultrasound is one to rule out abdominal mets. So what about bone scan? Bone scan is not recommended. So it has got it can cause fetal anomalies. So we don't do any bone scan in breast cancer during pregnancy. And tumor markers, are they recommended, like CA 15.5, CA 125, which are usually raised in pregnancy also. So there is no role of tumor markers in pregnancy. So what is the role of PET CT scan? We don't have, we shouldn't do PET CT scans because that also has got teratogenic effect. So it is only minimum of ultrasound, breast ultrasound, then if biopsy is proven, mammogram, and then followed with liver scan and then chest X-ray. So next, you have to keep in mind that chemotherapy should be avoided in the first trimester. Sentinel lymph node biopsy is an option with the 99M technetium sulfur colloid. Blue dye should be avoided, which is teratogenic. So management, we divide into breast cancer, early breast cancer, locally advanced, and then metastatic. So what do you do in early breast cancer? If she is diagnosed in first trimester, medical termination of pregnancy if patient desires, or if at all, if she wants to conceive, continue the pregnancy, then you have to give her the counseling. Counseling should be done. Multidisciplinary team should be included. So counseling is very important part of the management. And then at the wait till she comes to the second trimester, if you can wait. If it's a very early disease, we can wait. But then neoadjuvant chemotherapy can be an option to keep the disease in control. But if we diagnose in second trimester, mastectomy is the option. So here there's no role of lumpectomy. So mastectomy is preferred. As I said, because lumpectomy, if you do, we'll have to give adjuvant radiation, which should be not administered during pregnancy. So mastectomy preferred along with axillary lymph node dissection or sentinel lymph node biopsy also is acceptable. Then adjuvant, if adjuvant chemotherapy is needed, then we start it in the second and third trimester, and we have to stop it before before 35 or 36 weeks of pregnancy. At least 3 to 4 weeks of chemotherapy free duration should be there before delivery. Then after 36 weeks, if she is diagnosed, you delay the treatment and start the treatment after the delivery. So there's no harm in waiting for a couple of weeks. Avoid iatrogenic preterm delivery, allow for spontaneous delivery. This is about early breast cancer. So what about locally advanced breast cancer? If first trimester is there, as I said, medical MTP, one option, or if she wants to continue, then start her with neoadjuvant. Chemotherapy is not an option here because again, it is teratogenic to the fetus. So if it is very less and the low grade tumors, if she gives the consent to wait, she can wait. Then second trimester, mastectomy with axillary lymph node dissection or sentinel lymph node biopsy. Then chemotherapy in second and third trimester can be administered safely. So what is the role of radiation therapy? Here, can we administer radiation after mastectomy? That is, if there is indication for radiation, can we administer? Here, after first trimester, that is during early second trimester, maybe between that 14 weeks to 18 weeks or 20 weeks, we can shield the abdomen with a proper shielding. We can still give adjuvant radiation if it is really required. So weighing the risks and benefits. Okay, because the radiation dose administered is inversely proportional to the distance between the organ target organ. So here, chest, breast to the chest we are giving. So the organ is in the pelvis. So definitely the distance between them is quite far off. So fetal radiation exposure will be less. So definitely in between that 14 weeks to 18 to 20 weeks, you can administer radiation if it is required. So highly selective cases, you can give radiation. Otherwise, better to avoid radiation during pregnancy as itself. So even if it is locally advanced, we can wait if patient is diagnosed after 36 weeks, let her get delivery done and then start the treatment. So if metastatic breast cancer is diagnosed, then definitely medical termination of pregnancy if in the first trimester. Then chemotherapy should be started in the second and third trimester. Then radiation in selected selected cases, as I said. If it is more than 36, again, you can delay, but here also counseling is very important because survival of metastatic breast cancer, you should make her understand what is the survival rate. But now since treatment for breast cancer is highly evolved with many types of chemotherapy and targeted therapy, hormonal therapy, etc., definitely we can prolong the survival years. So even in metastatic breast cancer, we can treat them aggressively. And if diagnosed the third trimester, definitely we can try to salvage the baby also. So this is the chart showing the management according to the trimester itself. So even first trimester, modified radical mastectomy with the axillary lymph node or sentinel lymph node, then chemotherapy in the second, and after delivery, send her for radiation and then hormonal therapy. So hormonal therapy is also contraindicated during pregnancy. Then if it is diagnosed in the second trimester or early third trimester, then surgical management plus or minus adjuvant chemotherapy can be given. Then plus or minus adjuvant radiation and hormonal and adjuvant targeted therapy also can be given after delivery. So late third trimester, you can wait until she delivers if more than 36 weeks and then do a surgical management. And according to the stage, give her the adjuvant therapy. So what about the hormonal therapy? Because so many, 70% of them on hormone, ER/PR positive. So they express the hormones and we put them on hormonal therapy after the primary treatment of breast cancer. So here, do we give tamoxifen for the patient during pregnancy? It is definitely contraindicated at any time during the course of pregnancy because it is shown to have teratogenic effect on the fetus. So then we have HER2 positive tumors are there. So do we give trastuzumab? So second and third trimester chemotherapy we give safely, but can we give trastuzumab that time? HER2, which is anti-HER2? No, we cannot give because it crosses the placenta at increasing level, starts in the second trimester. So it has shown to cause severe oligohydramnias and severe IUGR and stillbirths also. So usually target trastuzumab is not advised during pregnancy. So wait for her to deliver and then you administer. Yeah.
Dr. Shobha, can you make it full screen? Yes.
Yeah, okay. So next, coming to the cervical cancer, which we have come across at quite, I think this is the one which we have seen maybe. So how do we diagnose cervical cancer during pregnancy? A patient comes with some kind of abnormal discharge or bleeding or some kind of pelvic discomfort, pain. So, but good thing about this is that most of the cervical cancer diagnosed with pregnancy is early stage. Unlike what we diagnose in a non-pregnant ladies, where most of them are advanced stage, here it is 60% of them are in early stage. So it is good for us that we can give her a good management. So actually, it is best diagnosed by cytology compared to the biopsy or colposcopy. So cytology accuracy is up to 60 to 70%. So abnormal cytology. So when you do a routine pap smear during pregnancy, you can come across with an abnormal cells, which is suggestive of carcinoma or high-grade dysplasia. Then you go ahead to do colposcopy, which is very difficult to kind of come to a conclusion in pregnant lady colposcopy. But still, nevertheless, we can see an abnormal area and take biopsy as such. So most of them are diagnosed, as I said, in stage 1. And for staging purpose, we do an MRI. So here MRI is done without contrast. So gadolinium is not used because that also, I mean, it's not, we don't have level 1 evidence to show it is teratogenic, but it can cause allergic reactions and it is not safe, is what is recommended. So contrast agent is not recommended. Whole body diffusion weighted images, MRI, can be used safely. So that will give us a proper cervical, I mean, tumor size and parametrial extension, whether bladder involved or rectum involved or parametrium is involved. So MRI is a good diagnostic tool without contrast. How do we manage? So here, definitive treatment should be done regardless of the gestational age in these cases, wherever we have documented lymph node metastasis. So whenever there is a positive lymph node metastasis, definitive management is required. Or when we see progression of disease during the pregnancy, so we have given her some kind of treatment, but we see there is progression of disease, then definitely we have to give her a definitive treatment. Or when patient chooses to terminate the pregnancy, so we have to respect her decision and then go ahead with the definitive treatment. So definitive treatment meaning the radical surgery is what we do for cervical cancer. So if the cervical cancer is diagnosed within less than 22 weeks of gestational age, then what we can do is we can do a laparoscopic PLND. Then first only with biopsy, we should ask whether there is an LVSI positive or not. Then do a laparoscopic PLND, and then accordingly you can plan. So if it is 1A1, one second. So pregnancy preserving management option is there up to stage 1B1. Okay. So what are the surgical procedure options we have? One is conization, simple trachelectomy, then radical trachelectomy is there, but if feasible, you try to avoid. So which can be done vaginally, abdominally, or minimally invasive. So radical trachelectomy unless it is required, we don't go to do a radical trachelectomy. So most of the cancers, as I said, it's diagnosed in stage 1A. Most of them conization and simple trachelectomy will be enough. So stage 1A1. So where lymph node metastasis is very, very less, conization is enough. But when do we do this? In second trimester. So first trimester, no surgical attempt should be done. Second trimester, we do a conization. Then of course, we have protective circlage followed by protective circlage. Then if it is 1A2 or if it is a 1B1, then along with conization and simple trachelectomy, lymph node assessment should be done. So it could be either laparoscopically, lymph node assessment, or laparotomy wise. So if lymph node is positive, then you have to counsel the patient and take up for immediate treatment with the regular recommended one. If it is 1B2, so if the lesion is less than 2 centimeters, then option of neoadjuvant chemotherapy can be given. Along with you do pelvic lymph node dissection or not is an option, but you can give neoadjuvant chemotherapy, control the tumor growth until the fetus become viable. So NACT stabilizes the disease, and once the fetal maturity happens, then do a cesarean section followed by radical hysterectomy. So if it is 1B3, that is more than 4 centimeters of lesion, then we have to consider for termination of pregnancy. Okay, fetus is not viable. But if they want desire to continue, then NICT option can be given, but explain to her the progression of the disease. So if in spite of giving neoadjuvant chemotherapy, if there is progression of disease, then we'll have to take a active decision on removing the uterus. So this is the chart showing that what all we can do. So cytology, then colposcopy and biopsy. Endocervical curettage is contraindicated. So we don't do endocervical curettage. So this is just what I told them. I can skip this. So even with this treatment with conization and simple trachelectomy, abortion rate we can have up to 9%, but good live birth rate is there up to 80%. And it is known that pregnancy as such do not progress the malignancy. So cancer cells are not growing because of pregnancy. Only when some cancer is an estrogen dependent cancer, then only there will be aggressive progression of cancer. Otherwise, usually pregnancy do not aggressively progress the cancer detected during pregnancy. Then coming to the ovarian cancer diagnosed during pregnancy. So most of the ovarian cancers, ovarian tumors diagnosed during pregnancy will be benign. So it could be dermoid or cystadenomas, which are 85%. So we can have then functional cysts, then borderline tumors, then epithelial tumors. So non-epithelial tumors like germ cell tumors are quite rare here. So benign ones most common, dermoid, functional cysts next common. Then we can have borderline tumors, which are 5%, and epithelial serous tumors about 5%, or mucinous tumors about 5%. So yeah, is what I told. Yeah. So if they are diagnosed in the apparently early disease, like it's confined to ovaries itself, then how do we proceed? So preferably around 22 weeks, you can do a surgical staging. So is there a role of laparoscopy here or laparotomy? So studies have shown that laparoscopy is quite safe enough. So if it is done by an expert and you do by an open method, and then you keep the pressure to a low settings between 11 to 12 mm, and then what else is there? And you have to finish the surgical surgery within 90 to 120 minutes. So these must be the prerequisites which we have to fulfill when we go for laparoscopic surgery. So then what do we do here? So we remove the, if ovarian mass is there, then we remove that and then send for frozen section, and then do a complete surgical staging like infracholecommentectomy, appendicectomy if it's a mucinous tumor, and then peritoneal washings we take, and multiple peritoneal biopsies. If suspicious, then lymph node dissections. Then if next the report comes as a high-grade carcinoma, or if it is wherein chemotherapy is indicated, if capsule is breached, then chemotherapy is indicated. Then we can administer chemotherapy in the second and third trimester safely. So here also the abortion rates and is around 8 to 9%, and then live birth rate is around 78%. So usually it is seen that in the second trimester, 20 to 22 weeks, when you do a surgical management, the uterus, the fetus in uterus is undisturbed most of the time with your preventive tocolytics, etc. Yeah, if it is an apparently advanced stage, like your imaging shows peritoneal deposits or omental caking, then what do we do? So if it is in first trimester, then definitely you have to advise for termination of pregnancy, go in for debulking surgery, and then adjuvant chemotherapy. But if patient insists for fetal preservation, then you can take a biopsy, go see for the histology, either with FNAC of omental nodule or adnexectomy or anything, get an histology, and then administer neoadjuvant chemotherapy after explaining the prognosis. Then debulking after the delivery should be done. Yeah, this is what I said, the role of laparoscopy, which is studies have shown you can do safely, but do if only done in the early trimester, that is around 20 to 22 weeks. Open method should be followed by an highly expert, low pressures, then surgery should be over maximum by 120 minutes. So here also, what is the role of CT scan? CT scan usually with contrast we do, but here we in pregnancy CT scan with contrast is not recommended. CT scan itself is not recommended because the radiation it emits ionizing radiation, so we do not ask for CT scan. So whole body diffusion weighted images MRI is what is recommended without contrast. So that has shown that accuracy is quite good. Yes.
So sorry for interrupting. How many minutes? Because we are running out of time.
Okay. I'll hasten fast.
Okay. Thank you.
So then, as I said, this is just a tabular column showing how you can manage. Okay. So if this is management of epithelial cancer, so either you can do a biopsy or a nephrectomy, send for frozen. If it's borderline, don't do anything close. Then after the delivery, do a staging, complete staging. If it comes as epithelial cancer, if it is limited to one ovary, then if it is less than 22 weeks, no indication of chemotherapy, you don't have to do anything. Then if there is indication for chemotherapy, consider chemotherapy in second or third trimester. Then staging should be done after delivery. So if there is peritoneal spread, less than 22 weeks, consider pregnancy termination. More than 22 weeks is there, then you have to do debulking surgery after delivery. That if patient insists to continue. Yeah, so this is about the non-epithelial cancer. So usually it is very rare germ cell tumors, X-cord tumors, what we see. And most of the time it is early. So just adnexectomy and intracollicumentectomy will suffice. So that is between 20 to 22 weeks. And upper abdomen and all, most of the time it is normal. So chemotherapy if required. So BEP is what we administer to them. So bleomycin is what we have to emit. Etoposide and cisplatin can be given safely in the second and third trimester. Yeah. Sorry, so I think it's jumbled up. Okay, then coming to the vulval cancer in pregnancy, it is very, very rare. So which we'll have to, if there is a small lesion in the vulva, then biopsy can be taken. Or if there's some kind of leukoplakia, which is persisting itching symptoms, is a vulvoscopy guided biopsy we can take. Then for staging, MRI is what we recommend. Here, early stage local excision and central node, the groin region is enough. If it is advanced, where radiation concurrent RTCT is required, then we'll have to delay it. We can delay. Consider delay 6 to 8 weeks if fetus is viable. But if RT cannot be delayed, like if it is a positive inguinal node, then we'll have to ask for termination of pregnancy. These are very, very rare. We hardly see that. So just coming to the administration of chemotherapy during pregnancy, as I said, very safe in second and third trimester. Taxanes, platinum, anthracyclines, etoposide, vincristine can be used safely. Okay, whatever we use in breast cancer, ovarian cancer can be used safely in second and third trimester. Anti-VEGF like Bevas and other anti-angiogenic drugs are contraindicated. Targeted therapy also are not administered due to lack of safety evidence. So rules, general rules, what we have to keep in mind: do not administer during first trimester. Use the standard protocol. Use the proper dose according to the actual body weight. Don't try to compensate. Maintain the dose intensity. Do not increase or decrease the dose. Then discontinue chemotherapy between 35 to 37 weeks. At least give 3 weeks of gap for termination of pregnancy, because both mother and fetus have to come out of myelosuppression. So hormonal therapy, it's contraindicated in pregnancy because it blocks the estrogen production or interfere with estrogen pathway and negatively impacts the pregnancy. So tamoxifen causes 25% of birth defects, especially it's something called as golden hour syndrome, ambiguous genitalia, etc. Then aromatase inhibitors also have shown to cause prenatal developmental toxicity. So letrozole also, it has shown toxicity. Nowadays, I think letrozole has been tried in ectopic pregnancy also because of its showing inhibition of estrogen synthesis. So radiation to be avoided during pregnancy, only in selective cases given the early second trimester. So up to 100, between 100 to 500 milligrays, it causes mental retardation. So if it's administered in first trimester 6%, second trimester 2%, but then when you give in first trimester, abortion is bound to happen. Then special abdominal shielding will reduce. Whenever you have to give, you have to do proper abdominal shielding. That will reduce the fetal radiation dose by 25 to 50%. So if RT is planned after termination of pregnancy, then you see to that you keep the ovaries away from the RT field. So yeah, this is the same thing what I said. So here we have to keep in mind the major oncology goal is survival outcome. So reassuring the data regarding prognosis of mother should be definitely kept in mind. All cancers, studies have shown that when we have combined all cancer, adjusting for age, extent of the disease, diagnostic period and survival, the survival did not differ in pregnant and non-pregnant cancers. So breast cancer had got the same disease-free survival and overall survival when compared to a non-pregnant female, but only some subgroups showed who showed HER2 positive had poor outcome. So they had little aggressive effect. Yeah. And then when the diagnosed during lactation period or postpartum period, it was shown to be aggressive, some subgroup in breast cancer. But apart from that, cervical, ovarian, lymphomas, leukemias did not have any kind of differences in the survival, whether it is diagnosed in pregnancy or in non-pregnant female. But malignant melanoma is the one cancer which showed there is increased risk of cause-specific death. Yeah, what the prognosis, as I said, prognosis depends on the stage and the treatment administered. Then early stage, if there, the prognosis is the same. So if cancer survivors have subsequent pregnancy, it is shown to reduce the cause-specific death by 80%. So this is the healthy mother effect, we say. So pregnancy following survival of the one cancer is definitely protective. So always you should think of the obstetric management. So here, what is the main thing? So obstetric monitoring should follow the guidelines of high-risk pregnancy. So whatever guidelines for your high-risk pregnancy is there, you do the same thing. So then whatever chemotherapy she has taken, the possible individual side effects of that chemotherapy should be kept in mind. Like if anthracyclines are given, so whether it has an effect on the heart of mother or then fetus after delivery should be kept in mind. So whatever it is, the goal is optimal care for expecting parents, unborn baby, balancing benefits of the oncotherapy carefully. Then seeing the fetal development, not only in utero, even after post-delivery, we have to see the fetal development. So give them adequate postnatal care. So I think the same thing. So in the second trimester, the most important side effect is intrauterine growth retardation. And small for gestational babies, they are very common. So they can, these can go in for preterm deliveries. So that is, preterm deliveries is one high risk for development of low cognitive development and low IQ. So that can happen in 20 to 30% of them. So PROM, stillbirths in 1%, not much. So ICU admission because of this preterm delivery is known to be around 40%. So term delivery is always preferred, no iatrogenic induction, wait for the spontaneous delivery. Only when it is absolutely required, you induce. Then chemotherapy is paused after 35 weeks. In absence of other obstetrics risk factor, vaginal delivery can be preferred, except for in other cancers like cervical cancer. Of course, you can't opt for vaginal delivery. Or if they're having some bone mets, then we can't allow them for vaginal delivery. So then cesarean section is a must. Then placental examination, histopathological examination is a must to exclude metastasis, because placenta is the barrier between the mother and the fetus, and also it's a kind of transmitting organ, right? So we don't know what all has been transmitted through the placenta. So we have to examine placental examination without fail. And breastfeeding is allowed if the chemotherapy has been stopped 3 weeks prior. So CT drugs which can be transmitted in milk are like cisplatin, methotrexate, doxorubicin. So if she's on these drugs, definitely she should not feed the baby. So targeted therapy like imatinib, which we give in just tumor, then and that also is known to transmit through breast milk. So how do you do fetal follow-up after intrauterine exposure? So we have, studies have shown that there is moderate cognitive developmental alterations, brain organization and functional connectivity is not negatively affected because of exposure in the second or third trimester. But some have shown that ejection fraction and fractional shortening and intraventricular septal thickness has reduced significantly, but it is normal. So in the babies who are exposed to the anthracyclines in utero. So these are the changes which we can anticipate in the newborn baby. So cisplatin exposed kids can develop hearing loss. So that also auditory test should be done. So this is after delivery, what all you have to do is this chart depicts examination of placenta, then neonate, immediate examination of neonate. Then you have to register the family, both mother and child with consent, then a regular follow-up and until the kid becomes an adult. So, blood counts, then evaluation of auditory function, then echocardiogram is the most important thing because most of them are exposed to anthracyclines, and neurocognitive development assessed by a psychologist or a neurologist, and neuromotor development, all those should be kept, and definitely genetic consultation should be offered. So this at regular intervals up till 17 years. So the fertility issues before we start chemotherapy or radiation, radiation of course we won't give during pregnancy. Before starting chemotherapy, ovarian tissue cryopreservation and the use of GnRH agonists can be done. The most important thing is psychological impact. So as such, pregnancy-induced changes have got a lot of impact on psychologically on mother. So cancer, again, it adds to the emotional chaos. So most susceptible women are to distress. So 51% can have distress, mood disorders, post-traumatic distress syndrome, depression, anxiety, adjustment disorders, postpartum maternal mental disorders. All these can cause preterm delivery, so which is the most common obstetric complication. So counseling for distress is the most important thing once the female is diagnosed with cancer in pregnancy. We should never ignore that aspect and take a professional help. So to conclude, gestational cancer is challenging to diagnose and to manage, should be managed by a multidisciplinary team. So diagnostic and therapeutic procedure, whatever we follow in pregnancy, should have the same efficacy of what we follow in non-pregnancy. But and the treatment option given should not affect the development and the long-term outcome of the unborn baby. Then surgery feasible option in gynec cancer is preferred in second trimester. Chemotherapy agent can be given safely in the second and third trimester until 3 weeks, 35 weeks. But avoid iatrogenic preterm delivery. Yeah, the same thing. So biopsy. So this is just a chart which shows chemotherapy can be given in second, third trimester. Endocrine therapy not to be given at all. Postpartum you can give. Targeted therapy also post-delivery only we can give. So post-delivery everything is allowed. Surgery is allowed in the all first trimester very rarely, so second trimester and third trimester. Thank you.
Thank you, Shobha, for the wonderful session. So always should keep in mind as a gist of your talk, the first trimester better to go for termination of pregnancy, and second and third trimester we can proceed with surgery. And chemotherapy also can be considered in a few cases. Yes. So most of the time, we should always try to go in for preventing the premature deliveries.
Yes.
And almost whatever it is always the prevention and screening in early birth. So we should never forget to examine the breast when the woman comes to us during the first antenatal visit. So of course, carcinoma, vulva, vagina, they might come with some symptoms, but we should always keep in mind about carcinoma of the breast with early clinical intervention and including carcinoma of the cervix. I would like to ask one question to you, Shobha, like what about the screening for carcinoma cervix during pregnancy? Actually, they say we have to do pap smear.
Yeah, pap smear is quite sensitive. So cytological reporting is accurate up to 60%. So I think pap smear is quite acceptable. I think that number is quite acceptable. So yes, first trimester, whenever you diagnose the pregnancy, definitely we should not forget to do a pap smear, because that is the time obstetric care they come. So screening with pap should not be forgotten.
Prevention is like more in the hands of the gynecologist.
Yeah, if by chance some dysplasia or CIN is suspected on pap smear, then do we have to go for colposcopy is the next question. So again, colposcopy is quite complicated in pregnancy. So, but if along with that, if she has some kind of symptoms, or if you feel it is pap smear, yes, discuss with the cytologist. If they feel yes, it is more towards a high grade of dysplasia, then definitely you have to do a colposcopy. Or you can defer after delivery.
Dr. Kasturi, your comments, please.
Very nice elaborative talk, Dr. Shobha, and they have dealt with in detail practical inputs which we can put it back into a practice. But anyway, we very rarely we see. I had seen a case of clear breast, and but it was diagnosed postnatally. Actually, she never had symptoms or anything.
Okay.
She was unbooked. And after delivery, she was feeling some plump. Then we saw that it was just what is this thing? Then it was. But as you told,
and most of them, they mistake it for a breast abscess, madam. Like lactation period. So that time again the delay in diagnosis.
Yeah. But luckily we sent it for all this thing, and we diagnosed, and she could take treatment, and baby was put on formula feeds, and so that was okay. Nice. And so many times we do see cervix cases, but problem is once we tell patient like it is malignancy, psychologically they are not in interest to continue the pregnancy and take all the risk. When we tell the imaging carries so much risk and the chemotherapy causes so much risk usually, and if it is within 24 weeks, it's okay, but afterwards it becomes so difficult to convince them about continuing. So these are practical difficulties which we face, And second and third trimester NACT you all give. So which chemotherapeutic agents you all are using?
Paclitaxel, carboplatin, safely we can give. No problem.
But after taking the consent, that still it may be cause some.
Yes. So, long-term effect on the fetus, it can cause very minimal thing, but it's quite safe.
We never know what kind of changes it is causing.
So
because it does cross through the placenta and
yes.
And what about the imaging? I just wanted to know, because when we do CT, MRI, because in pregnancy, CT we avoid in case, because it is essential if you do here, what kind of counseling and consent you are taking?
Here, ultrasound, basic ultrasound is the best, madam, for any, breast cancer, or you want cervix, MRI, but not without contrast. So contrast is definitely not recommended. So now whole body diffuse weighted images they do without contrast in MRI. So that shows accurate lymph node pickup also. So that's quite good. So we can go for MRI without contrast. So diffusion weighted.
Not to use the contrast is the carry-home message for all, because routinely everybody writes MRI with contrast.
Correct.
Contrast does gets absorbed, and it does circulate. It is seen. It is even detected in the amniotic fluid. And the baby swallows that, and that goes through the fetal kidneys, and it affects
can have some
effects on the fetal kidneys long term. So we are not supposed to use any kind of contrast for imaging during pregnancy. So that is excellent talk, very important. Though we see rarely, it will really help us in management of these cases.
I try to concise in limited.
After thanking the chairpersons night, I think Dr. Shobha, with your permission, We have
Yeah.
lots of doubts in our mind, the need of preconceptional pap smear, preconceptional mammosonography. There are lots of doubts in our mind. So we move on to our rapid fire round section. That's the question answer section. So see here, what we have done is our committee members have tried to get in more questions from individual societies. We have a set of questions which will be moderated by consultants of Motherhood Hospital, Dr. Madhura Pathak and Dr. Shweta Naik. I call upon on behalf of our committee, Dr. Arunima from Belgaum to introduce Dr. Madhura. Let's make it a rapid fire round so that we won't waste our time much. Most of the questions are answered, but still a lot of consultants have posted their questions.
Okay.
Dr. Arunima?
Yeah. Everyone, ma'am, myself, Dr. Arunima, I represent a Safe Motherhood Committee from Belgaum OBG Society. It's an honor to introduce Dr. Madhura Pathak, ma'am. She is a consultant obstetrician gynecologist at Motherhood Hospital, Mysore. Ma'am has finished her MBBS from Kasturba Medical College, Bangalore, and MS from Bangalore Medical College. She has finished her MRCOG from Royal College of Obstetrician Gynae in 2007. She worked in UK hospitals from 2005 to 2015. And at present, she's a consultant at Columbia Asia Manipal Hospital, Mysore, 2015 to 2022. Recently, into 2020, she has become a fellow fellow of Royal College of Gynae. Ma'am also has other fellowships in gynae laparoscopy, urogynecology, and colposcopy. Welcome to the board, ma'am.
Thank you.
Thank you, Dr. Arunima. I now quickly call upon our Safe Motherhood representative from Hassan, Dr. Srividya, to introduce Dr. Shweta Naik.
Good evening, everyone. Thank you, Dr. Sonia, for giving me the opportunity to introduce our next moderator for the session, Dr. Shweta Naik. She is consultant obstetrician and gynecologist from Motherhood Hospital, Mysore. She has completed her MBBS from WIMS Ballari, DNB from CSI Hospital, Mysore. She has worked in various institutions at various capacities, namely in Chelwamba Hospital, MMCRI, Narayana Hospital, Kamakshi Hospital, Mysore. Madam has completed her fellowships in ultrasound training in obstetrics and gynecology and infertility from Baby Science ART Clinic. Welcome you, ma'am, on behalf of Safe Motherhood Committee.
Thank you.
Thank you, Dr. Srividya. I request Dr. Madhura and Dr. Shweta Naik to forward the questions for discussion with Dr. Shobha and the other senior members in this platform. Over to you.
Okay. Hello, everyone. It was such a informative session and rejuvenating all our forgotten knowledge about malignancy during pregnancy. Yeah, first of all, a heartfelt thank you for organizing such an interesting CME. First, I thank you, Dr. Sonia, Dr. Hiremat sir, and Dr. Hema ma'am for conducting such a CME, and Dr. Shobha for a wonderful session. Thank you so much.
Thank you. Thank you.
And we know that as we are practicing as high-risk gynecologists, we know that in near future, we are really going to get increasing number of malignancies during pregnancy. Yeah, that is because the age of pregnancy is increasing and all the pregnancies are associated with one or the other risk factors, like either age, obesity, medical conditions, or lifestyle disorders, narcotics usage, smoking, alcohol, whatnot. Otherwise, at least some psychiatric illness as well. So, along with all these conditions, when we need to practice, we better be armed and have good knowledge about these conditions so that we can have a better decision-making capacity. Though we involve oncologists, oncosurgeons during this, but we still need a good knowledge about these conditions. And without not much wasting much of the time, let me just proceed to the first question. That is, a 35-year-old lady whose husband is on imatinib molecular targeted therapy for CML. His blast counts are normal. It's a spontaneous conception. Now the question is, can she continue pregnancy? Will the drug have any effect on fetus and pregnancy outcome? What are the chances of that baby getting the disease in the long run?
So husband is on imatinib, right?
Yeah.
So I think it is quite safe for her to continue the pregnancy. So if she was on imatinib and then the fetus is exposed to imatinib, definitely there are high chances of fetal anomalies and abortions, defects, etc. But now since husband is there and then that thing has, you said, I mean, normally they've conceived. So conception is normal also.
Spontaneous
So
conception.
yeah, spontaneous conception. Very unlikely for this one. Definitely she can continue the pregnancy.
What I understand is probably the intention behind this question is whether the fetus will have any genetic abnormalities. Probably that's what they are like. Yeah, they are intending to ask whether his sperms have been affected or not. Probably. I think we need to do.
No, I don't think so. No, I mean, studies are very, very kind of rare. I mean, this is a rare scenario. Like, so if we see imatinib is a maintenance they take for years together. So if semen is normalized only, I think normal conception is highly possible. So I think that is very unlikely that semen has been kind of having some kind of side effects. You know?
So we should not worry.
Yeah, can continue.
Okay. The second question is,
I think any andrologists are there, they can also take up the question and answer. Yeah.
The second question is, do the malignant tumors grow during pregnancy? And what is the effect of pregnancy on tumors?
No, definitely no. There's no adverse impact of pregnancy on tumors detected during pregnancy. So definitely not. So many cancers are detected early, in fact. Like as I said, cervical cancer also is detected early stage. So they do better. Ovary also is detected early. So they do better. So there's no adverse impact of pregnancy on tumor.
Okay, fine. And the third question is radiotherapy possible in breast cancer cases during pregnancy?
Usually it has to be avoided. So preferably avoid radiation. So if at all
if it is required, then I think with abdominal shield.
Shielding, yes. So if it is later, in later term, then because her abdominal gestation age, uterine size would have increased. So direct effect to fetus is more. So that time preferably not to be given, like in third trimester. So anywhere between.
Also did mention about 14 to 80, 20 weeks.
18, 20 weeks, yes. So that time we can, with the proper special shielding, we can give. So where it is absolutely required, or we can wait until she delivers.
Okay. Could I just interrupt Dr. Shweta? There's one question in the chat box. When patient is started on chemotherapy, should she be put on folic acid throughout pregnancy, or till when she has to be given?
No, it's not routinely recommended. So the first
as an
preconception,
I feel that yes, folic acid, yes. As an observation, yes.
I thought the first 3 months, yes, definitely. Then I don't know. Do you really routinely put on all high-risk pregnancy folic acid?
No, for epileptic patients we do put, but I don't know for malignant.
So it is treated like a high-risk. All guidelines same for what you follow for high-risk pregnancy is what should be followed in pregnancy after that treatment.
Okay, madam, I would like to ask one more sub question for that. If suppose if a lady takes radiation during the pregnancy, is there any chance of the fetus having high risk of leukemia during their lifetime?
Yes, there are chances. So the blood cells are affected. So in utero exposure of radiation, they can have. It can be affected.
So that's why we delay radiation during pregnancy, isn't it?
So most of the time, spontaneous abortion will occur if by chance the radiation is direct to the fetus. So if the fetus survives, then definitely all this teratogenic
effects will be there. Okay. And the next question is, can thyroid scans with
Now, is Dr. Madhura,
Yeah, she'll take it.
Madhura there?
Yeah.
Dr. Madhura
Once
also.
Shweta finishes, I'll carry on.
Yes, but we want to see you on screen. Okay.
Okay. Can thyroid scans with radioactive iodine uptake be done in second or third trimester of pregnancy?
No, actually, it is not recommended. So during pregnancy, any thyroid scan with radioactive uptake is not recommended. Not recommended.
Okay, so it's not.
So if at all, if you have to do just a thyroid scan, if it's indicated for anything.
Okay, fine.
Ultrasound.
Fine. And the fifth question is chemotherapy withheld prior to delivery? If so, then when preferably it should be restarted? I think you have answered this question.
Yeah.
Yeah.
So we will stop 3 to 4 weeks prior to termination of pregnancy, and then after her delivery, if we have not completed chemotherapy still, so then if we again restart the chemotherapy, definitely that time she has to stop feeding. So during chemotherapy, usually because all the cytotoxic drug is transmitted through, most of the drug which I quoted is transmitted through the breast milk. Yeah. So avoid.
Yeah, and the next question is like
Dr. Shweta will come back to your question first. Again, we had Dr. Sunaina Rao who had some questions from Manipal Society. Madam, is your questions answered?
Those were asked. The first 2 questions were from there.
Okay. And Dr. Rekha from Shimoga also had some questions. Do you want to?
Yes, ma'am. What is the role of pap smear in pregnancy? You said,
as I said,
yes, we should do it in first
yes,
trimester.
we can do up to 60% sensitivity accuracy is there. So definitely that is one
So it should
opportunity
be-
for us to screen them.
Okay, ma'am. It should be a routine part of ANC care.
Routine, yes.
And also breast examination.
Yes, definitely.
And ma'am, how do we manage any breast lump in the lactating period? I think most of us neglect assuming that it is a galactoseme. Is it necessary to do FNAC for any breast lump in a lactating mother?
Yeah, first thing is get it examined by an expert. Could be a general surgeon or a gynecologist or a oncologist or whoever, but with an expert. Just go and get it examined, and then if it looks suspicious, like all the other clinical signs and symptoms is indicative of some kind of abscess or infection, then definitely they'll put on a course of antibiotic and then again reassess after antibiotics. So again, if it seems suspicious, then ultrasound is what is recommended. So in ultrasound, as we get the category, whether it is category 3 or 4, then accordingly we'll have to ask for biopsy.
But,
so here,
right away we'll not ask for FNAC.
yeah,
That's what
right away we won't. So as I said, cancer as such is rare thing. So first thing, what is common, we suspect that. So breast abscess or galactosemes are more common.
Okay. Ma'am, and what is the role of non-invasive screening tests in pregnancy with cancer? All this PAT, beta HCG, all this, will they, do they still have the same significance, or do they lose
No,
the significance?
No, usually in pregnancy.
Yes, ma'am. In pregnancy with cancer.
Usually tumor markers in pregnancy only will be elevated, like CA125 or CA15.3, SCC. All these will be elevated as such. So it is not very specific. So only when it is, and especially early stages, it doesn't raise much. So we don't know whether elevation is due to pregnancy or due to cancer.
Because of the
So so tumor markers are not very specific here.
Ma'am, that
So
is
whatever
about
we are
okay, ma'am, that is about tumor markers.
screening.
Yes, ma'am. But what I'm asking is about all this, double marker tests and triple marker tests. Do they still hold their value in pregnancy with cancer?
I don't know, you people should tell me that.
Again, I think as
obstetrician, you should tell me that.
I don't think the malignancy is going to alter the hormonal pattern
Correct.
for what you're
I
doing.
would like to know one thing, whether NIPT has any role in diagnosing the PACs?
No, yes, NIPT, because of increased usage of NIPT, the incidence of picking up cancer, some kind of syndromes,
Yes.
genetic,
Yes.
definitely it is there. Yeah, it has concurrently picked up.
Okay. Over to you, Dr. Shweta.
Yeah.
Thank you.
Ma'am, I would like to ask you one more thing. Now we have something known as stem cell available for all the patients. Do stem cells have a role in treating leukemia, patients who have leukemia with pregnancy? Does the stem cells obtained from the baby have any role in treating the mother?
Obtained from baby, yeah? So you have to get into termination first to get a viable baby for that.
Okay.
So,
okay. While getting the baby itself, like the mother reaches 28 weeks, and while delivering, if you procure some stem cells, will that be of any help to the mother? Like for leukemias and lymphomas and AMLs, CMLs.
I really
I think, because the purpose
like
of stem cell is that.
Yeah. Okay.
We don't have a long time study on that.
Probably we do.
Yeah,
it does have
evidence-based
a
study. Yeah, maybe in future.
Maybe in future it might. Yeah. And ma'am, the next question is like, is it true that meningiomas grow during pregnancy?
Meningiomas are estrogen dependent, so they can grow.
Yeah.
So, but most of them occurring in younger age group are usually benign.
Yeah.
And if it is a malignant one, then depending on whether the grade, the extent, and the location where it is, or whether they've attempted for an excision before, that it can again start growing, aggressively, if it is a malignant one. But if it's a benign one, usually it don't, but it is estrogen dependent, so there is chances of it growing.
And I'm happy to tell you that I had managed a case of meningioma during pregnancy.
Oh, really?
Dr.
Nice.
Yeah, we terminated her at around 28 weeks, and she was located at the basal
skull base.
And and
that is a very
800 gram, and both of them survived very well.
Oh, very nice, very nice. Did you report this case report? You should do this. No, you should do this. See, this is one. I mean, where we lack our data is this. So.
Yeah. Oh, really? I'll try to do this.
Yeah. Please. Yeah, you should.
Okay. And the next question is, which malignancy can metastasize to placenta and fetus?
Most of our gynec malignancy usually do not metastasize to placenta, but malignant melanomas and some hematological malignancies can metastasize. There are chances are there. But otherwise, breast, ovarian, cervical, usually they do not.
Okay.
Malignant melanoma is supposed to be little
aggressive. Okay.
Yeah.
With this, I thank Dr. Shobha for such a wonderful session once again. And I'll hand it over to Dr. Madhura. She'll be leading the session henceforth. Thank you so much.
Thank you.
Thank you,
Shweta. I have a few questions. I think Dr. Rekha already asked you, but I'll just read out these questions. One is, why is tamoxifen contraindicated during pregnancy in breast cancer? I think that was also answered by you.
Yeah. Lot of fetal adverse effects are there, teratogenic effect.
Yeah. And I just leave out the questions that Dr. Rekha asked just now. The next one is role of placental histopathology and neonatal tests. I think you did have a slide on
that.
Yes. So always placental examination, histopathological examination is very important. So it is, see, in utero, it is the connection between the fetus and the mother, right? So whatever is going is through the placenta. So be it nutrition or even cytotoxic drug when it's giving, so it is passing through the placenta. So it is definitely affecting the placenta also. So to what extent it can be affected is then it has an adverse effect on the fetus. So if there is abnormality of the placenta, then it can have an IUGR, or they can have a, pregnancy-induced hypertension. Those kind also can happen.
and then preterm delivery can happen. And also definitely if it is cytotoxic drugs which are highly teratogenic, when some kind of, what we are giving is safe, but still if the dosage is excessive or anything, it can have some long-term effect to the fetus. So we'll have to examine the placenta for that. So is there a kind of abnormal placenta or normal placenta? So examination of placenta is important after delivery.
The next one is evaluation of breast pump during lactation period. I think that you answered just now.
Yeah.
But I have one question with this. So we nowadays see that people getting mammograms and ultrasound kind of screening. So which is better in mammogram better or ultrasound screening for the breast is better?
Depends on the type of breast. So dense breast, what the content of the breast. So, but most of them after 50 years, mammogram is the recommended screening modality because microcalcification is picked up better in mammogram. So if between that 40 to 45 or 50 years, and then who are little reluctant to undergo mammogram because, it's quite painful. So they would have heard that they don't want to undergo mammogram. Then maybe first as a first screening modality, you can ask for a ultrasound. And then if a radiologist is picking up something abnormal, then he will ask for supplementary mammogram. But above
Nowadays
50,
we are seeing a lot of fibrocystic disease.
Yes. Maybe it is hormone related. So a lot of changes in younger age groups. So they're exposed to hormones from very early. So we don't know what the reason is. We have puberty occurring in very young girls. And then we have a lot of infertility. So all that has an impact on this yet to be answered.
The next one, I think, is an important one. Preconceptional counseling in patients with gynae cancers, uterine, breast, and ovarian cancer. That's the next question.
Sorry.
Dr. Madhura, you repeat the question?
It's about preconceptional counseling in patients with gynae cancers.
Yeah, definitely. This is after treatment, you mean? After treatment of gynae cancers. So most of the time we would have seen which stage she is in, which kind of cancer she has been surviving, and then whether chemotherapy has been taken, and then the duration is important when she wants to conceive. So if chemotherapy has been taken, at least minimum period of 1 year should be conception free, like she should not plan. So, but if if she was advanced case, stage 3 ovarian cancer or aggressive variety of tumor, then definitely we'll ask them to wait for 2 years because we want to see, because recurrences are quite common in this first 2 years. So if there's no evidence of recurrence, then we'll ask them for go ahead for planning for conception. That is the first thing they have to keep in mind. So, but whatever chemotherapy effects means within 1 year, 12 months, it will wear off. And of course, preconceptional folic acid, all those things, definitely important one. And of course, after chemotherapy, there are some fertility issues. So on the ovaries, they can have premature ovarian failure depending on what chemotherapy. So if cyclophosphamide has been taken, like in what we give for GTN, so Emaco we give. So there, if there is it can have an impact on fertility. So the premature menopause or oocyte, reserve might be less. So all that issues should be kept in mind. So I think they have to approach to an infertility specialist from the initial stage itself, not wasting more time.
So, but then continuing for the question, if in case they are to start chemo, just before starting chemo, I think they can actually adopt.
Cryopreservation, oocyte preservation. Yes, definitely. All young patients who are desirous of fertility preservation, we do send them to an infertility specialist where the options are given to them. Yeah, depending on their financial support, if they can go, then we wait for that stimulation or oocyte preservation, and then they send back to start chemo. Yeah.
Yes.
The next question is the change in ART protocols in uterine cancer.
Uterine cancer. I think an infertility specialist can answer.
It depends
that.
on which stage, I think.
Yeah.
Okay.
So
I just interrupt here. I recognize that Dr.
Yeah.
Bharti Rajshekhar had to leave. Ma'am, if you have not left yet, Madam had one question. I think, ma'am, we would definitely want to let you go only after you speak.
Oh my God, I finished speaking. You are giving a very elaborate overview of management of malignancies in pregnancy, and I was in and out of my clinical commitments. Well, there was one question I wanted to ask, that routinely, do you suggest that, because how do we pick up cervical cancer in pregnancy? So is there a protocol, this high risk group or age that we need to do a routine cervical examination? Because we see that many obstetricians very sadly do not do a speculum examination for pregnancy. Even if there is a lady complains of vaginitis, they don't do.
Discharge,
Unfortunately,
yes.
we are not doing the speculum examination. Then how would you pick up a cervical lesion unless we have a routine protocol for screening?
Yeah, as I said, first time when they come for confirmation of pregnancy, I think first examination itself, we have to put a speculum and examine. At least we will know that time cervical changes is still not to the maximum. So we will know whether it is a normal looking cervix or abnormal looking cervix. So that time only, if it is a suspicious kind of cervix, definitely we know she must be harboring some pre-invasive condition, and then accordingly take a cytology and then go in for colposcopic examination.
Yeah, I think.
And maybe if we put a leading question, then they might answer that yes, postcoital spotting. That is the most important. I mean, I think an important symptom which most of the ladies won't share unless we ask it as a leading question. So post,
As it is, I think all of us need to put a speculum.
Speculum and
just doing the scans, repeated scans we are doing, because we have seen that when they come with bleeding PVC, threatened abortion, we think only of threatened abortion in pregnancy.
Correct. Yes.
When I started my practice about almost 30 years back, there was a young girl who came and we did a speculum examination. First there was nothing, then we did 1 or 2 scans, and in those scans the patient was okay. Then she said every 2 days she was coming with spotting. And then when we did a speculum, she had just a very maybe less than 2 to 3, maybe less than 5 millimeters. There was a small pustule-like small speck of growth on the. We did a biopsy and it came as clear cell carcinoma of the cervix.
Oh my God.
That was, I think, way back in the 80s. And unfortunately, she terminated the pregnancy. She was in Bangalore. She underwent surgery and chemo and all those things, but she succumbed to the disease. So I think all threatened abortion, not threatened abortion, all early pregnancies, we have to make it a point that do a
examine the speculum.
And a suspicious cervix to do a smear.
Is very important.
So otherwise we are
point brought up.
there. And the other thing is examining the breast for every pregnant mother.
Yes, that's a routine.
Yeah, a very meticulous examination, not a cursory examination.
Yes, true.
Yeah, thank you. Talk to you to us, Shobha.
Thank you, madam.
Thank you so much.
I thank Sonia and Dr. Sunaina and Madhura for conducting the question answer session. I'm sure there are many more questions, but yeah, somebody has a question which one of you can take, Shobha. Should we do a regular pack?
Yeah, definitely, yes.
Dr. Madhura, do you have any more questions?
There was just about role of tumor markers in pregnancy. I think that was answered.
Yeah, not very specific. So because it can be elevated due to pregnancy also, we do not.
Yeah, I have one question. What about women who have a precancerous, I mean endometrial hyperplasia with atypia? How do we manage them before pregnancy if they are planning for pregnancy?
Yeah, you can definitely do a fertility preserving management here. So medical management is what we opt for. So complex, I mean, atypia, definitely 30% chances of it going for malignancy. So first thing is definitely we have to rule out there is no underlying invasion. So our biopsy should be adequate, and a pathologist who is reporting should have done a good job. So these two should be kept in mind. So then if there is no invasion, then you can go in for hormonal therapy. So you can LNG, so intrauterine device with LNG can be safely put along with oral. So they might not, that dose might not be enough to revert back. So along with LNG, we give them oral progesterones also. So then every 3 months, we'll have to do an endometrial biopsy, pipple biopsy. So endometrial aspiration, and then see whether it is reverting back. So if it is not reverted, it's the same, then you can increase the oral dose somewhat. And then after 6 months, again repeat. So if it's reverting back, well and good, wait. So previously we used to wait for 2 normal reports, but now recommendation says 1 normal report also. Immediately you can ask her to go for ART. So that is the recommendation.
Okay, we have one last question we can take up from the chat box. That is prophylactic cerclage mandatory after all conization surgeries?
Yes, I think so.
But will it not be very
I mean,
difficult for us
you will ask, I mean, you will have to look for the length of the cervix. So whatever your recommendation is there, where cerclage is needed, that length here also similar, you'll have to follow.
I think we'll have much difficulty to do an encerclage otherwise, post-conization.
Post-conization, yeah.
Okay. Do any more questions, Dr. Madhuri?
I have one question.
Just about mine. Yeah.
Yes. Yes, Dr. Rekha?
Ma'am, do you recommend OCPs for a couple of years, say 5 years, to young girls who are at risk for developing ovarian cancer? Or is it only a theoretical advantage, or you practically advise?
No. It is chemoprophylaxis. So if there is a risk of her developing, if she falls into that high risk population, like if you, I mean, you would have done a genetic counseling. So if she has a strong family history, or if she's a breast cancer survivor and who will be more prone for second malignancy in the uterus or ovaries, then of course, definitely we will give this option of risk reducing chemoprophylaxis.
Thank you, ma'am. Thanks for answering all my questions. Thank you so much.
Okay, I think it's time for us to wind off. And before I call upon Dr. Vidya Thobi, our president-elect, one question from Dr. Beena, I think. When to do the pap smear after any pregnancy event? She means postpartum or post-miscarriage. This is her question.
Yeah, postpartum or I think you can wait for the normal physiological changes to revert back. So it could be 3 to 4 weeks. After that, you can do.
All right. And GI malignancies in pregnancy, what's the prognosis by Karan Shetty?
GI malignancies are quite rare. So reporting, I mean, whatever literature I have seen, it's not very common. Colorectal is there, but that also depends on the stage, detected stage. So if it is early detection, definitely they'll also do as good as non-pregnant females. But their chemotoxicity will be more.
Yes.
Yeah.
Okay. Thank you so much. And one valuable question before valuable remarks from Dr. Vidya Thobi. One question, Dr. Shobha. Yeah. Any medico-legal issues you have faced till date?
No, I haven't.
With malignancy and pregnancy?
No, I haven't.
Okay, then congratulations to you.
Thank you.
Dr. Vidya.
So I have come across, my personal, this one was ovarian tumors itself. So ovarian tumors and cervical cancer early. But as they had finished the family, she opted for radical hysterectomy. Ovarian cancer, 20-22 weeks, I did an ovariotomy and self-injectomy with omentectomy, then gave her chemotherapy. So etoposide and cisplatin, and she delivered, she's having a good fetal outcome also, no problem.
Okay. Madam, Dr. Vidya Thobi? I guess Madam is present. See, Dr. Shobha, Dr. Sudha was also trying to reach out to the chat box. I guess.
Okay.
Yes, Madam, Dr. Sudha. Now, Dr. Vidya Tobi, if she is not here, I would like valuable expert opinion from Dr. Sudha, your own professor. Madam, unmute. Sudha,
Hi, Shobha.
Hi, hello.
I am online. Hi, Shobha. That's it.
Hello. No. Hello, madam. How are you?
I was feeling proud of all my students who have gathered today.
Thank you so much, madam. So nice to see you after so many. So nice to see you after so many days. Thank you, madam.
Madam,
We'll meet you sometime. Bye.
Madam, your valuable remarks at the end of the session concerned with this topic, madam.
And the topic was very well discussed by Shobha. She went all except the GAT malignancies she covered, and probably neural disorders she missed, I think, malignancies, brain tumors. Because we do some brain tumor, post-brain tumor.
Oh, okay. Madam, for this only they were not giving me time. Okay.
Next time include that. Okay.
Sure,
Okay,
madam.
bye then.
Sure.
Bye.
Bye. Thank you, madam.
Thank you very much, madam. And we come to the wrap-up round, the last round where I would definitely want to introduce and thank the sponsors of today's entire virtual platform. See, sponsors are a very important part of any webinar. So we putting in mind that they play a crucial role in the provision of financial support, for which Team Safe Motherhood Committee would want to thank wholeheartedly Mr. Sandeep, who is a pillar of Motherhood Hospital, Mysore. Mr. Sandeep, are you here? Yes, we would definitely want to hear from you.
Namaste to all. On behalf of, I thank Kasauga President, Secretary, and Safe Motherhood Committee Chairperson Dr. Sonia Mandappa ma'am for giving the program. Thank you once again, ma'am. Thank you one and all.
Thank you so much.
Thank you.
Thanks for the patient listening. All audience have been waiting for the questionnaire session. Now our vibrant, very interactive representative of our committee, Dr. Sunaina Rao, represents the Manipal Society. She would deliver the concluding vote of thanks. Over to you, ma'am.
Thank you, madam. Thank you, Sonia, madam. Good evening, everyone. Thank you is a prayer that cannot be seen or touched, but can only be felt by our heart. I feel honored to get this opportunity to propose a vote of thanks on this special occasion. I would like to thank all our honorable senior members who have blessed us with their presence. Words are simply insufficient to thank them for their constant guidance and support in shaping this webinar. On behalf of the Safe Motherhood Committee, Kasauga, I thank all the esteemed members of Kasauga State Committee, which includes Dr. M.G. Hiremat, Chief Patron Kasauga, who is also our chief guest today. Madam Kasturi Donimat, President Kasauga, Madam Vidya Tobi, President-elect, Dr. Bharti Rajshekar, Honorary Secretary, Dr. Durgadas Asarana, Treasurer. A big thanks to all of you. And also Dr. Shobha Vembergi, who is a zonal coordinator of our Safe Motherhood Committee. Special thanks to our guest of honor, Madam Hema Divakar, Dean of KCOG. Thank you, Madam, for always being there to guide us. Many thanks to our web coordinator, Kasauga, Madam Manjula Patil, who coordinates and plays a vital role. Sincere thanks to our wonderful speaker, Dr. Shobha K, President-elect KSC AGOI. It was an excellent presentation. Thank you, Madam, for elaborating and simplifying this complex topic where management and treatment pose unique challenges to us obstetricians who have to confront ethical and emotional treatment dilemmas while making decisions for the mother as well as the fetus in such a difficult scenario of malignancy with pregnancy. Many thanks to our chairpersons, Dr. Kasturi Donimat, our President, Dr. Suma KB, Professor and Unit Chief JSSMC Mysuru, for conducting this vibrant session. With immense gratitude, I also thank our moderators of the questions and answer session, Dr. Madhura Patak and Dr. Shweta Naik, both consultants from Motherhood Hospital, Mysuru. I'm also proud of our Safe Motherhood Committee representatives from various societies, Dr. Rekha, Dr. Arunima, Dr. Srividya, Dr. Rashmi, and wish to express our appreciation for their constant contribution and sincere support. I earnestly thank our sponsors and the entire team of Motherhood Women and Children's Hospital, Mysuru, and Mr. Sandeep for his support. Now, I wish to wholeheartedly acknowledge and thank our convener, our very own chairperson of Safe Motherhood Committee, Kasoga, Madam Sonia Mandappa, for the tremendous amount of work she has put in for making this webinar a success. And finally, heartfelt thanks to all our doctor colleagues who have joined in big numbers. I could see more than 60 members at one time who actively participated in this webinar. Thank you, everyone. Namaste.
Thank you, Dr. Sunaina. Before we wind up, and I actually want to thank Mr. Arun. Mr. Arun, who's actually visualized as admin. He's been the backbone for all the presentations. And we from the Team Safe Motherhood Committee congratulate and thank you for the same. But before we switch off the system, Mr. Arun, I want a video of Motherhood Hospital. And then say good night to all and Shubhratri to all.
Thank you. Thank you.
Play Martira, Arun sir. From Mysore Motherhood Hospital. I immensely thank Dr. Madhura Patak and Dr. Shweta Naik who accepted the invitation of moderating the question and answer session. Thank you so much.
Thank you. Thank you, Dr. Sonia, for inviting me.
Thank you.
It's a pleasure. Thank you. Good
Thank
night.
you so much, Dr. Shobha, and all the very best. Many more to go. We look forward to invite you for many more platforms and panel discussions henceforth. Thank you so much.
Definitely.
Good
We
night.
have a Kasoga preventive oncology also. We can do something together.
Yes, we will definitely take it up.
Yeah.
Thanks so much.
Thank you.
Thank you.
Thank you.
Thank you so much.
Good night.
Thank you.
Bye. Good night. Thank you.